Hi guys, welcome to Inspire Sports Physio Podcast, where we make physio less intimidating and more fun, bringing educational bite-sized tips and tricks to you and conversations with world-class athletes and performers where you can learn from their mistakes so you don't have to. I'm Emily Mitchell, a physiotherapist and equestrian stunt performer. So, first things first, what is pain? You might just be thinking it's a signal that says something's wrong, and in a way you are right. But pain is a little bit more sophisticated than that. According to the International Association for the Study of Pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So, did you notice two things out of that sentence there? One, pain is both sensory and emotional. So yes, your brain is involved, and that explains why sometimes when you stub your toe it feels way worse than it should. Two, pain doesn't always correlate perfectly to tissue damage. So this means that you can have significant pain without major injury, or an injury with surprisingly little pain. So it can happen either way. So think of pain like your body's fire alarm. Sometimes that alarm is right on. It goes completely off when it smells burnt toast, and sometimes it barely whispers even when there is an actual fire. So understanding the pathophysiology helps us to figure out why the alarm is sometimes a little bit oversensitive or undersensitive. So let's start at the periphery with nociception. This is a fancy word for how our body detects harmful stimuli. Nociceptors are specialized sensory neurons that respond to mechanical, thermal, or chemical stimuli. So, imagine this as tiny little tripwires under your skin and in your muscles. Once them tripwires under your skin has been activated, that signal has traveled to the spinal cord. It gets to the spinal cord, it then gets modulated. So, neurotransmitters pass the message along, and this is where pain modulation starts. So, even before your brain's involved, there's a little bit of tweaking of the message of how much is this a threat or not once it's got to your spinal cord. So from the spinal cord, the pain then travels up the spinal thalamic tract to the brain, specifically the thalamus, which acts like a relay station. So what happens here at the thalamus? So this is a part of the brain, and it sends different types of information to multiple areas of the brain. So we've got the somatosensory cortex, and this is where your brain perceives where you're hurting. So is it the toe? Is it the hand? Is it the arm? Then we've got another signal that goes to the limbic system. This triggers the emotional response. So why stubbed toes can make you cranky, grumpy, a little bit angry because you've stumped your toe, because that's where the information's gone to the limbic system, and that's where you get your emotional response. Then we get your frontal cortex, which interprets and rationalizes the pain. So this tells us how much are we in danger, and it interprets it. Have we seen this threat before? If we have, what was the response? Do we need to respond faster, quicker, slower? So think of pain like a fire drill message. The nociceptor sets off the alarm, the thalamus acts like a central dispatcher, and the cortex interprets what action you should take. This explains why two people with the same injury can experience very, very differently the types of pain. So this is also another thing what at physio school we got taught. If we see a patient and they've had an MRI, they've had an x-ray, that means pretty much nothing to us, because we don't treat the scans, we treat the symptoms. And that is literally because of this concept that two people could have the same scan for osteoarthritis, one where it's bone on bone, technically should be crippling, and the other where actually there's a little bit of degeneration, but actually the joint is still preserved, yet the person who's bone on bone be asymptomatic and can have no pain whatsoever. This is another part that I found really interesting, is the modulation and the gate control theory of pain. So not all pain signals get to the brain, but this is where the gate control theory comes in. So this was proposed by Malzak and Wall in 1965, and they suggested that a gate the spinal cord, can either amplify or dampen the pain signal before it even reaches the brain. So factors that can close the gate is stimulation of non-nociceptive fibers. So if you think you've banged your elbow, your funny elbow, what do you do after you've banged your funny elbow? Normally, the common response is you go to rub that elbow and go, ooh, and that is you're giving the brain extra stimulus to think about because you're in pain. So this can dampen the original pain effect. We've also got endogenous opioids, which is your body's natural painkillers. And let me tell you, what is one way that you can release these natural painkillers? Well, one is what every physio's bread and butter is, and that is movement and exercise. So through movement, through exercise, we release our natural painkillers. There is a lot more, it gets a lot more complex than just movement, but for today, we'll just say that yes, movement can act as the natural body's painkiller system. We've also then got psychological factors like distraction, relaxation, meditation, all them different types of relaxating things that can dampen down the pain signal. Sometimes pain outlives its usefulness, and that's when things get tricky. This is where we talk about chronic pain, often involving central sensitization, where the nervous system becomes hypersensitive. What does this mean? The peripheral nociceptors keep firing even after the tissue's healed. So you can have healthy tissue, but there's a bit of an error, computer error, and the signals keep getting sent to the spinal cord saying, hold on a minute, there's a problem here, and the brain then perceives and says, oh, we've got pain here because it's had that prior experience. We've also got then some spinal neurons that become a bit more excitable. So if you imagine you've got one baby in the pool pit, and you've got another one and another one, more kids together, they seem to go hypersensitive, hyper excitable, and you've got so many kids screaming, and this is a little bit the same as the spinal neurons. So it's like your fire alarm's developed a personality disorder. Even a gentle toast burn will trigger a full-blown panic. So this is where physiotherapy comes in, because we help treating chronic pain. It's not just about the tissues, it's about retraining the nervous system, integrating understanding why the pain persists, which helps to reduce fear and catastrophizing, because if we don't understand why the pain's there and why it's constantly getting worse and worse and worse, this negativity mindset, it's a little bit adding fuel to that fire that's already started. So we're only making a fire bigger if we are fearful of movement, if we've got different understanding and beliefs around pain. So this is why it's really important as a patient, as a clinician, to educate patients of why that pain is persisting to help reduce fear. We also include multimodal strategies. So as I mentioned before, we've got our body's natural opioid system, so that's exercise. As physios, we can use manual therapy. We can have cognitive behavioral approaches. So again, it's rewiring that mind-body connection. And sometimes a pharmacological has a role to play too in some cases. So remember, our goal isn't just to reduce pain, it's to restore function, confidence, and most importantly, a quality of life. So that's a wrap for today's episode around pain. If you enjoyed this episode, hit subscribe, leave a review, share it with a friend. Until next time, I'll see you soon. Take care. Bye.